And I'll be happy to present our next speakers, that will explain even more and in details the potential of advanced MRI for the assessment of the fetal brain insults. Professor Liat Ben-Sira and Professor Daphna Ben Bashat. Professor Liat Ben-Sira, she is the head of the pediatric radiology in our hospital, and we work with her very, very closely. We learn from her all the time, and as I showed in my presentation, we cannot make this differential diagnosis without the use of the MRI. Professor Daphna Ben Bashat is the head of the Sagol Institute, and she works behind the scenes with all the technical development and the innovation for the MRI field. So I'm sure that you will enjoy a lot their talk. Thank you very much.
First, can you see my presentation?
Yes.
Okay, so first, Nina, thanks for inviting us to give this lecture, and it's an honor, and thank all people that participate. So what we will talk is the potential of advanced MRI and what MRI is currently being used for assessment of fetal brain insult, but what other methods and what is the potential of additional use. So in general, MRI is increasingly being used, and it may provide important information to confirm or ultrasound findings and alter or modify patient management. And indeed, there are many studies during the last year that compares cohorts with MRI and ultrasound, and they do show improving diagnosis and optimized clinical management, especially in brain malformation. Regarding safety, MRI has been confirmed as a safety for pregnant women, mainly during the second half of gestational age. However, there are some studies that show MRI at younger ages. However, there might be less advantages. And it has been confirmed both in 1.5 Tesla and 3 Tesla. So what are the advantages of MRI? It can provide multiparametric information, meaning if we talk about CT or ultrasound and it provides us a structural malformation and CT perfusion or Doppler is a second contrast, MRI can provide a lot of structural, functional, and metabolic information. So if we talk about conventional methods, and all the methods can provide true 3D information, meaning we can get true volumetric assessment of brain structures, of ventricles volume, of lesion. And the conventional methods usually are just the images coming out of the scanners directly to radiologists. But the rest of the methods, the raw data is not so informative. There is some post-processing and a lot of image analysis tool. And what we get at the end are parameters. So there is a lot of structural connectivity, which I will talk about, all the diffusion-based methods, which are relevant in this talk. There is also metabolic information, which is the only imaging method that can indirectly provide any information regarding the metabolism, in this case within the brain. There is a lot of vascular imaging methods, most of them in a postnatal, and we'll talk about the limitation, why not all of them can be applied prenatal and what are the modifications needed. And another bunch of methods looking at the functional of the neuron, which just currently are not very used in prenatal, but they have the potential maybe to see death in CMV. So there are some studies, but I will not talk about it here. So what are all this information? In generally, we can get more than 30 parameters characterizing microstructural properties of the tissue, meaning we have macro scale, but indirectly it detects the micro scale. So the conventional imaging, what you know is the T1 and T2. These are only weighted images. Usually after 2 years of age, we don't see any changes because it's not quantitative measures. But we do have the T1 measurements, or 1 over T1, which is the R1, or 1 over T2, which is the R2, which does show changes along age. It's indirectly reflect the water content, maturation of the tissue. So we really talk about and see information regarding the tissue integrity. All the diffusion methods, which I'll also talk about later, they are indirectly reflect the cell size, myelination, axonal injury, fiber organization. So we can get a lot of information, and it's important to understand that each method is a new acquisition. It's not something that we get the data and then we can extract all this beautiful information. We need to know in advance. Each sequence, each method takes additional time, which extend the scanning time of the fetus. In adults, we have the post-contrast enhancement. We inject contrast agent, gadolinium-based, and in clinical routine, we just see if there is enhancement in lesion, meaning yes or no blood-brain barrier permeability. But there are beautiful methods that we can quantify this permeability and not just say there is permeability, but how much, because in brain tumors there are more, in neurological disorders there are less permeability. So all these methods are available in MRI. And they're all, most of them, used postnatally. They used all these methods to detect neural integrity and assessment of structure and function, metabolic. So postnatally, we can use this method. Unfortunately, in prenatal imaging is lag behind. We rely mostly on conventional anatomical sequences, and although we provide true 3D information, assessment, similar to ultrasound, is subjective, mainly qualitative, and there are only a few quantitative assessments performed manually, which are based on linear measurements. For example, if we want to see ventricle dilation of the ventricles, so we do some measurements, and when we look at volume, there are some discrepancy because it depends where we measure. So these are the limitations of prenatal imaging. So what we do in prenatal imaging, we mainly rely on T2 weighted images to assess the size of the brain, symmetry, sulcation, ventricle, and normal structure. Why T2? Why not T1? Because in adults, when we want to get a good contrast between gray and white matter, we use T1 weighted image. And you can see white matter is white in T1 on adults, but white matter is white on T2 weighted in the fetus. And this is actually the situation almost until the age of 6 months. And this is because of the high content of water in the white matter. There are fast imaging methods, mainly for the T2, which make it more feasible for us to use it to get structural. So most of the imaging in fetal assessment is based on T2 in different orientation, in different slice thickness, like we heard before, but are based on T2. If you want to see pathology beyond structure, then we do use the other sequences. We use the T1, as you heard a lot before. We use the T2 and the T2 star. And this T2 star is a very sensitive method for any susceptibility. And so we can see hemorrhage very pronounced on T2 and mainly T2 star, as you can see in this example. And more example in the use of this, Professor Ben Bashat will talk about after I finish this part. And there is a lot of longitudinal or dynamic changes with T2 star if we talk about hemorrhage. And this is a simple diagram which is not always happening in the clinic, the changes in T2 and T1, and this depends on the changes between oxyhemoglobin to deoxyhemoglobin to metahemoglobin, and changes in the ferrum oxygenation level, and changes its magnetic properties. So theoretically, if we follow up this pattern, we can know when the hemorrhage happened, and we can get some information about the timing. Not if it's 2 weeks before or 3 weeks, but if it's pretty new or acute hemorrhage, then we can know this based on the changes in the T2 and T1. What else can we know? We can get also information about the parenchyma that we heard so much about it, how much it's affected. And there is a whole bunch of diffusion-based methods, starting with conventional, which is a very simple method, diffusion tensor imaging, I will talk, that can give us information about reorganization of the white matter fibers, and advanced diffusion currently are mostly in research. So when we talk about diffusion, what is diffusion? Diffusion is just a Brownian motion of water molecule spontaneously. And when we talk about cellular tissue, diffusion is influenced by the cellular compartment. If we're talking about diffusion within the cell, it's pretty restricted. If we're talking about diffusion of water molecule at the extracellular, extravascular space, this is a free diffusion. And on the time scale of MRI, we assume that the water molecule within the cell will not go out to the extracellular space. Once there is a stroke, once there is a stroke and we get some cell swelling, the extracellular space shrink and then we get restricted diffusion. That's why on diffusion weighted, we get hyper signal immediately after stroke. And this method, this was a really killing application of diffusion because it's the only method that can show changes in the parenchyma immediately after stroke when CT or MRI does not show, and they show changes only a couple of hours after stroke. And there are other methods of diffusion, because diffusion is not isotropic, there are direction. So if we try to mimic the direction of the diffusion, and if we are talking about white matter fibers, along the fibers we get free diffusion, but perpendicular to the fibers it's restricted. And if we get the information on the right information with a mathematical model, we can get this fraction anisotropic of the water molecule. We can know the direction, whether it's anterior, posterior, right to left. And if we look just on the average, then we can see also the apparent diffusion coefficient, also called sometimes the mean diffusivity, and the image. So all these methods are very sensitive, as we said, to the cell size. So we are sensitive to pathology, they're sensitive to maturation, so we can also follow up maturation of the fetal brain, because cells are growing, they are more myelinated, and we can see even premyelination changes in the diffusion. And we can see, if we're talking about T1 weighted image, above the age of 2, we don't see any difference. But if we're looking about fractional anisotropy, an advanced method, which is another diffusion based, then we can quantify changes along gestational age. Then we can see changes in different pathology, like in this case in autism. And of course, maturation is not homogeneous. And posterior region are more mature than anterior region. So we can really get a lot of information about brain maturation. So what about stroke? Postnatally, as we said, we use all these beautiful methods. There are clinical symptoms. So in general, we know where we expect to find the lesion of the stroke. We can have this angiography, MR angiography methods with or without contrast agent injection. There are methods that segment the blood vessels so we can know if it's an MCA, PCA, if it's a venous stroke. And we can, in the same method, know if it's hemorrhagic or infarct based on the T2 and the diffusion, if it's restricted, because in a hemorrhagic, there is no restriction, there is a free diffusion. And there is also some timeline in diffusion, because if we are looking immediately after stroke, as we said, there is cell swelling, so there is hyper signal on diffusion or reduced apparent diffusion coefficient. But if the stroke was severe after a week, 10 days, 2 weeks, depend on the location and the severity of the stroke, some of the cells are dying, so there is free diffusion. Some of them are still swelling, so there is a restrictor. And as a mean value, we see what we call pseudo-normalization. So it's important to understand that if there is no signal in diffusion on a single time point, but you do suspect to have a stroke, ischemic stroke, it might be that your just time of acquisition is in a place where it's pseudo-normalized, and it's better to rescan him again 2 weeks later. So in postnatal stroke, we also quantify the perfusion. We do inject contrast agent. There is a perfusion-weighted method that quantify the cerebral blood flow, and all the stroke assessment is based on what we call the perfusion-diffusion mismatch, or the penumbra, areas that there are restricted, there are reduced flow, but the tissue is not dead yet, meaning this tissue can be saved. But what can we do in fetal stroke? These beautiful methods of assessing the blood vessels is a long acquisition. Fetal is moving. There are some research, however, that started now to show a beautiful image of the blood vessels of the fetal's brain. All these perfusion methods are also irrelevant because they require the injection of a contrast agent, which is not performed in pregnant women. However, there is a method called arterial spin labeling, which is again still on a research phase, that without a contrast agent, we can get information about flow. This method we are currently used also to assess placental perfusion. And I hope in the future this will be part of routine assessment of fetal brain development. And of course, all this method of susceptibility weighted image is based on T2 star, just enhancing based on the phase image as well, and also the diffusion and ADC methods. But this is for differential diagnosis, and most of the talk till now was indeed focused on this. But what else can MRI be in addition or beyond differential diagnosis? So as we said, and there is a lot of trend in radiology in general and in MRI towards quantitative assessment. So we don't want just to measure the ventricle dilation. We want to have a true three-dimensional information, volumetric measurement of the ventricles or the proencephaly volume. We want to have a true volumetric assessment of the fetal itself. If there is hemorrhage, maybe we can measure it like we measure volume of lesion. So to have quantitative assessment, thus we can follow up in a quantitative mode. We want to talk about risk for perinatal stroke. So of course there are genetic risks and a lot of things from the mother and genetic or deficits in blood vessels, but we also know that the blood circulation of the fetus, the placenta, the cardiac, are also known as a risk factor for perinatal stroke. So we might want to assess the placenta and the cardiac to know if there are maybe very moderate or mild abnormality that can serve as a risk for perinatal stroke. So to assess its flow, to assess its integrity, to assess cardiac output. And there are recently studies and groups that are focused on assessing fetal cardiac using MRI. We want to talk about prognosis and again assess the tissue loss, assess the tissue integrity in the parenchymal injury. And all these beautiful methods on diffusion are applicable to fetal as well. And there are beautiful studies done by the group in Boston and in Oxford that they reconstruct three-dimensional fiber in order to predict the outcome of a newborn. If we want to assess also injury in the parenchyma and there's no structural abnormalities, then we can also look at the metabolites. And this is using MRS, and this is a study that we conduct now in Ichilov, trying to assess fetuses affected with CMV if there are no significant structural changes or there are no structural changes. And we want also to guide treatment because we know that the way the brain reorganizes, and there is a lot of brain plasticity in fetal and neonate, this might guide if we want to differentiate between constraint-induced movement therapy or other therapy, which is very important for pediatric neurology. And we show it on a few studies, a manuscript published on studies on children with CP, with hemiplegia due to perinatal stroke. We see the reorganization of the fibers. We see plasticity in the cortex, in the contralateral cortex, and we try to connect between brain reorganization following injury and outcome and guided therapy. So what just to conclude, what we should do with MRI beyond what is done. We want to implement advanced MRI methods, the vascular time of flight to see blood vessel, the arterial spin labeling, which is a perfusion without the need of contrast agent, and maybe even to look at the neuron function of neurons, to develop automatic methods for quantitative assessment of fetal development, what we call computer-aided diagnostic tools, because there is so much information, and if somebody, any radiologist will want to quantify, he will need days just to analyze the data of one fetus. So we need to introduce them with automatic methods to improve, and all this together will improve our understanding on the mechanism, define maybe imaging biomarkers for risk or for prognosis, and to guide treatment. And by that, I will just thank you and move it to Liat, and especially my students that did almost all the work, and all collaborators both in Ichilov and in other hospitals and in Canada. So thank you very much.